I am tasked with the job of telling you all about low-risk chest pain in 30 minutes. It's sort of the Twitter version of low-risk chest pain. 140 words or less discussing low-risk chest pain. It's quite a challenge. It's, I believe, what page is that, 145 in your book, in the Bible According to Rick. Let me tell you about low-risk chest pain. This is a huge conundrum. And we actually spent an hour on low-risk chest pain 2 years ago. We spent an hour on unstable angina, NSTEMI last year. And now I am tasked with discussing low-risk chest pain with you in a half an hour this year. What I'm going to do is sort of highlight the pitfalls for you and then give you a little bit of what I think is the take-home. I think for most of us, one of the things we've learned about chest pain as we kind of go on in our careers is that everybody lied to you in medical school. All right, I mean, they really did. I graduated from medical school completely understanding coronary artery disease. I understood MI, I knew how they presented, I knew what to do, and now it is this big mess. It's this big mess. Now, one of the reasons it's a big mess is kind of brought out in paper number 1, which is by Pope, which looks at the fact that we miss about 2% of MIs. Those of us that work in emergency departments in particular send home about 2% of MIs. Those people do worse. They have a doubled mortality compared to people that we take care of appropriately with MIs and admit. And what we've been doing is chasing for the last decade now, because this paper's 10 years old, chasing that 2% and chasing it and chasing it and chasing it. And honestly, I don't think we're ever going to be perfect in picking up all MIs. It's just too complicated. And there are sort of two schools of thought in this. One school of thought is it is so complicated that we should lowball it completely, do a little bit of screening stuff in the ER, and basically filter everybody through the chest pain unit on their way out before they get their treadmill. It's almost like we should take everybody who comes in the ER, put them through the CT scanner from head to toe to make sure we pick up every disease that way. I like the MR scanner because they can suck off the weapons as well as they come through where I work. And then we should just put them all on the treadmill on the way out and we could diagnose the heart disease. And by the way, let's just catch everybody who's waiting for them in the waiting room with them because we could catch their disease as well. It's really, really complicated. Let me tell you the pitfalls. And then I'm going to try to give you some way to go home and have some way to practice. Because honestly, it's really become quite a quagmire. It's quite a sort of pit, this big pit of quicksand with this stuff. If we look at risk factors, we were all taught, that sort of starts the whole, do risk factors help us? The Framingham study brought out risk factors, and we all know what they are. There are 5 of them. And in fact, the residents have actually distilled them down to 3. Family history, history of smoking, and diatensionalemia. The residents have now kind of taken diabetes, hypertension, and hypercholesterolemia and put it into diatensionalemia because most of our patients have all 3, and they want to put them on lipoforminazide to kind of treat it all. The residents have come up with it. If they could market this, they'd make a fortune. Those are the risk factors. And what the Framingham study did is said these are the people at risk for heart disease. The problem is you in your office or those of us in the emergency department have someone right there, you, come in with a symptom or something that makes me think about acute coronary syndrome. Does that risk factor list help me at all in that individual patient? Let me tell you the pitfalls of this, and I'm going to take you sort of backwards in the order that Mel put this chapter together. If you go to number 5. Number 5 looks at the risk factors and how many people who have coronary artery disease or heart disease, some sort of heart disease, have a risk factor. This is a big population study, 122,000 patients in 14 clinical trials. And all of these people had heart disease. And they looked at them and said, okay, of those people, how many have a risk factor? And they found that most of them had a risk factor. Okay, fine. What they didn't do, though, is look at the presence of risk factors just in the normal population of people who don't have heart disease, right? Which is what I'd like to know. The next paper did that. The next paper looks at almost 400,000 patients, looks at risk factors. And they did find that people who have heart disease have risk factors. But they also found that at least one risk factor was present in anywhere between 58 and 85% of people who didn't have heart disease. Okay, now we're getting into the conundrum. Now we're getting into the problem. And if you go back to abstract number 2, which is by body, this one's a little more helpful to those of us that work in the acute setting. Someone comes into you with some sort of new symptom, individual patient, not population data, individual patient data. And this one took almost 800 patients. They all had chest pain suspicious of cardiac disease, the kind of people that we see. And they basically said, okay, how many of these people, first of all, had a heart attack or ACS? And of them, how many didn't have a risk factor. Okay, that is helpful to me. I find that kind of paper interesting. They found that there was acute MI in about 20%, 18.6%. 12% of those patients had no risk factor. What I think the take-home point for us is, on a one-on-one basis, me and a patient, not a population basis, me and a patient, what the take-home message from that is if the story's good, it sounds like an MI, it smells like ACS, it looks like ACS, it's ACS, risk factor or no risk factor. The other sort of flip side is, boy, it's a shoulder strain. It is definitely a shoulder strain. It's nothing but a shoulder strain, and they have diattensionalemia. Oh well, it's somebody with diattensionalemia with a shoulder strain. So this, I think the key is not to let the risk factors make you make your decision on that individual case. You've got to put it all together. And the way the risk factors are helpful, I think, are at the end, when I'm risk stratifying once I have all the data together. That, to me, is where they have the most impact. So risk factors, pitfall. And just know how to use them. And they don't really steer on an individual patient, steer you terribly one direction or another. Now, how about the history? We base a whole lot on the history. And I would love to tell you that the history is helpful. But unfortunately, sometimes it is. And it's wonderful if they come in saying it's crushing, and I'm sweaty, and I can't breathe, and oh, it's radiating to my left arm. Oh, my jaw is hurting. Good, excellent, thank you. That makes my life easier. But for ladies in the room, just to tell you a study that came out a couple of years ago, feeling a little tired this morning? Feeling particularly tired this morning? Really tired, sorry to tell you, but you're probably having an MI. The most common symptom in women, or a very common symptom in women, which is actually a paper we covered a couple of years ago, 70% of women who came in with an MI complained of unusual fatigue as one of their chief complaints. The other chief complaint that I have learned to have a great deal of respect for is shortness of breath, particularly new or different shortness of breath, especially in a woman or an older person. Those symptoms turn out to be sort of these weirdo, atypical symptoms that should clue you in. So if a woman comes in, she's 70 years old, she's otherwise doing okay, and she said, I feel like a dish rag. I am exhausted, and I have absolutely no idea why. She probably has ACS, and she may very well have had an MI. There's a paper in here that's kind of frustrating. It's abstract number 7 by Swap. It's a retrospective study, which always are full of pitfalls. Retrospective studies are always problematic. But what they did in this study, which I do think is helpful, is they looked at all the different complaints that people can come in with when they may have ACS. And they looked at things like reproducible chest pain. We always use that. Where's your pain? Right here. Well, if I push there, does it hurt? Oh, yeah, that's it. That's the pain I have. Does that help you determine ACS or not? The answer is probably yes. However, it doesn't rule it out entirely. What this paper does, what Swap's paper does, it's a big paper. Lots and lots of patients in this thing. It's huge. What this paper does is says certain complaints are much more likely to be ACS. And one of them, one that's very interesting, is radiation to the right shoulder. Interestingly, that turns out to be quite specific for ACS. And certain complaints make it less likely, but not zero likelihood of having acute coronary syndrome. Things like reproducible chest pain, particularly pinpoint kind of chest pain or pleuritic chest pain, make it less likely, but nothing is zero, which of course puts us a little bit on the hook. So I would love to tell you that the history you can hang your hat on 100% of the time. You have to make a clinical judgment. And I'll tell you the one thing that came out in the 2007 ACC-AHA guidelines for unstable angina, NSTEMI, and STEMI. They have this chart on how to interpret the patient's history. And they have all these typical complaints, and they have this little tiny side box on that paper that says, but please also consider atypical symptoms including, and then they have this list. Pleuritic chest pain, pinpoint chest pain, pain with movement, unusual fatigue, shortness of breath. They have this list. You're not off the hook in somebody who you think it's just focal chest pain and it's not ACS type symptoms. But you have to make it, it's sort of like with pulmonary embolism. You have to kind of put the whole picture together and make a clinical judgment. And I would love to tell you that if it's pinpoint and it's reproducible, it's not heart disease. I can't tell you that for sure. However, it is less likely. So don't shoot the messenger. It's just really a tough diagnosis to make in most patients. And history can be helpful if it's positive, if it's kind of really strongly sounds like ACS. But if it doesn't, you still kind of are on the hook. And there's actually another paper in here. This is Hollander's paper, number 8. That is a little bit problematic in that it was done by a lot of resident data gathered. But this paper said, okay, fine, say you think it's absolutely for sure, no question, that shoulder strain. Or it is absolutely for sure, no question, costochondritis. There's just no question. I'm 100% sure that's what's wrong here. They actually found that still a significant proportion of those patients went on to have ACS. In fact, anywhere between 2 and 4%. I don't know what to tell you here, except that this is a quicksand area. You've got to make it, and at some point you got to decide. I find myself thinking, okay, I read all these papers, it's like, you know, at some point I just have to make a decision. I can either swirl around in this conundrum of, oh my God, I don't know, or I just can make a decision and say, you know, for you, it's your shoulder. And I may miss it. But for you, I really think it's your shoulder. And for you, you have diattensionemia, and your history's a little bit squirrely, and I'm not so sure. Okay, so you have to kind of make it, you've got to find a place you're going to draw the line. And I wish I could tell you there's a really clear-cut place to put that. I can't. Now, how about the EKG then? It's fine. Okay, histories can be a problem. Let me get to something concrete. Let me get to that EKG. That'll help me, right? Maybe. A couple papers in here that look at the EKG, and I'm going to tell you some other data that's out there as well, because there's only one paper in here that Mel put in here, but there's a couple others that are helpful. We have a cardiologist at Harbor who's this bombastic, he's actually bigger than life kind of guy from Boston. He's big, he's got that Boston accent, which I really wish I could do, because it's hot. Of course he's a heart guy, hot. Is there a heart attack in here? He comes through the ER, you know, he's just this big bombastic guy, and he comes in and he will always say, he'll look at the EKG and he'll say, so is this chest pain? It's like, yeah, it's with chest pain. To get one without? Yes. Well, there's no change. It can't be acute coronary syndrome. Now, the guy's really smart. Is he right? Absolutely not. Absolutely not. Let me tell you some of the data. Turnipseed's paper's in here, which I don't think is as helpful as some of the other ones. But initially, normal EKGs are found in 6% of people who have an MI. 6%. If you have somebody who has an EKG with pain and an EKG without pain, and the EKG is unchanged, they have the same likelihood of having an MI, whether it changes with pain or without pain, depending on your clinical suspicion, okay, depending on the big picture here. So that doesn't help. If it changes while they're having pain, fabulous. Thank you. That's useful. If it doesn't, that is not useful. And a normal EKG does not rule out acute coronary syndrome. You know that. That's what NSTEMI is. You know, in NSTEMI, they don't have STEMI changes, and they can have a totally normal EKG. So EKGs, know how to interpret them, know the pitfalls of them, and know that your general suspicion trumps the EKG. And non-specific EKG changes are very scary. Okay, that non-specific doesn't mean non-cardiac. It can absolutely be cardiac. So beware the abnormal EKG, and in the right clinical scenario, the normal EKG does not rule it out, and changing with and without chest pain doesn't make a difference. It's, again, the big picture you're putting together based on some history, some tests, including the EKG, and your troponins. So be careful with the EKG. That's potentially problematic as well. By the way, there's a couple, what if the patient comes in and says, because this is actually a little next section here, Abstract 10 deals with this. You know, I had a treadmill a week ago and it was completely normal. Does that change what you do now? Absolutely not. Let me tell you a story. I was moonlighting a couple of years ago. There's a guy who turned 50. It was one of these marathon runners, super skinny, like no body fat kind of guys, super jock, Ironman guy. And he'd gone to his cardiologist and said, I'm 50, I want my risk stratification test. His cardiologist said, fine, ka-ching, I need a mortgage payment anyway, fine, let's go ahead and get your non-stress test, and put him on the treadmill. And the guy was a marathon runner, and by God, he was going to break that thing. He ran to like a Bruce 95. The guy went berserk. He went nuts on this thing and flew through. He did a great job and came in 12 hours later to me in the ER with a tombstone anterior MI, STEMI. Unbelievable anterior STEMI. Huge 7-millimeter ST elevations. You need to understand, and I think the data says we use these appropriately. You need to understand how you use these risk stratification non-invasive tests, these sort of, PMIBs, et cetera. They are helpful for that event, that day, those symptoms. They're helpful for that, and they're helpful for fixed disease. They're not helpful for the ruptured plaque 12 hours after his treadmill in this marathon running jock. Okay, he ruptured his plaque and got his MI 12 hours later. So we do the right thing on these things. And what the data says is those of us that see people on an acute basis, we say, gee, that's nice, you had a normal treadmill a week ago, but your history sounds really good right now, and I'm not sending you home. And we don't. The data's really good. We actually know, I think it's just because we're so nervous about this disease, but we know not to send somebody home. If they have, even if they have a normal treadmill, we're not to send them home if they come in with a good story. And by the way, they're just as likely to have an MI. Okay, the data's out there. Nirenberg's paper there talks about that. And how about risk? I want to wrap a little bit, but how about risk stratification tools? How many of you, where you work, use some sort of risk stratification that puts together sort of history, physical, EKG findings, troponin markers, et cetera? How many of you use a standard? I'm kind of curious, hands up. Because if you don't, I highly recommend you do. What we've done at our institution over the years is we've evolved into an ACS protocol that we all stick to, and we chose a certain, I'll tell you how we did it, but we chose a certain way to risk stratify patients because of all these difficulties and all these pitfalls with all the pieces. And the data says that if we go by our clinical judgment, if we just take all of us in the room and we put up 10 patients up here that may have acute coronary syndrome, and we all vote, I'd admit that one, I wouldn't admit that one, I'd admit that one, I wouldn't admit that one, we miss about 5%. If we just use our clinical judgment. And there's a couple papers in here that look at that. Christensen's is probably the best. There was a study that looked at trying to find, could we find a bunch of variables that make us really accurate in picking who has ACS and who doesn't. What they found is if we just use our clinical judgment, we're actually a little worse than using some sort of risk stratification scheme. So I recommend that you familiarize yourself with some of the risk stratification tools that are out there. And let me tell you about a couple of them, and then I'll tell you what we chose at Harbor and why. The one that's used most commonly is the Timmy score. Okay, the Timmy score is well known. It's actually in a lot of the papers that are out there that you read. And let me tell you the components of the Timmy score so you can tell me why it's problematic, because I think it's problematic. Age greater than 65 is one of the risk factors. By the way, you get a point for each of these things. Age greater than 65, that's cool, I can do that. You have to have greater than 3 coronary artery disease risk factors, and those are the classic ones that we all are familiar with. That one's cool, I'm fine with that. A history of known coronary artery disease, so somebody who's had a cath, they have known disease, or they've had stenting, they have known disease. Aspirin use in the last 7 days, severe angina, which is 2 or more episodes in the last 24 hours, ST segment changes greater than 0.5 millimeter up or down, and positive markers. That's pretty good. I can get all that data. I can get all that information. I can gather all that. Let me tell you what they found from this. If you have 6 to 7 of those risk factors, besides the fact you're kind of hosed, that's bad news, your likelihood of an MI is 41%. That's great. And I kind of wish everybody would walk in with all those risk factors that make my life easy. What if you have none of them? None. So you're not over 65. You're a 40-year-old person with no risk factors, no known coronary artery disease. You don't take aspirin. You haven't had 2 episodes of angina in the last 24 hours. Your EKG is totally normal and your markers are negative. We've all seen those people, right? According to Timmy, you have a 4.7% chance of an MI. Are you comfortable with that? I'm not comfortable with that. That's too high. Okay, that means I'm still missing 5. My clinical judgment's just as good as that. I'm still missing 5%. That's not good enough for me. And I'll tell you, the Timmy score wasn't developed for us on the front line. The Timmy score was developed to determine who gets what kind of treatments and when. The Timmy score was developed for cardiologists who say, thank you very much for this patient, and they whisk them off to wherever they take them. That's not what I need. I need a tool that says, I can send you home, and you need to stay. And I can be comfortable that when I send you home, you're going to be safe. You're not going to have an event. That's what I need. Timmy doesn't do it. Unfortunately, it doesn't. And Timmy's it's easy to use, but it's just not good enough. There are several other stratification tools out there. There's the GRACE score, which is difficult because it has lab values, including things like SGOTs in there. There's the Goldman criteria, which is actually superb. The Goldman criteria, actually, if you get to very low risk, and I'll tell you a second about the Goldman criteria. It's not really practical for us. It might be, but it's not really. The Goldman criteria, if you get to the very low risk group, you can stratify people into very low risk all the way up to high risk. In the very low risk group, it's 1.7% risk of MI. Okay, I'm getting down to a range now where I'm getting kind of comfortable. I'm getting a little better with this. The problem with the Goldman criteria is there are a boatload of factors you have to factor in, including things like BUN creatinine, SGOT. So you've got to, do you measure that routinely in your heart patients? Most of us don't. And there are a bunch of other things like listening for AS. There's a bunch of other things that make it very difficult. It's easy to use for in-house people, trying to evaluate somebody. It's easy to use for somebody doing risk stratification before surgery. It's not easy for us to use in the ER, but it's a good tool. Is there anything we can use in between? Is there anything that we can use in between? What we use at Harbor, what we decided to do is we went to the ACC-AHA guidelines and we pulled out the old standard Braunwald criteria. There are two tables that are involved in the Braunwald criteria. One is determining the risk of coronary artery disease, and it divides people into low, intermediate, and high. The other is a risk of a bad event in the next 72 hours, which is really what I care about in the emergency department. That's what I want to know. If I send this person home, are they going to have death in the next 72 hours? I'd like to know that. Are they going to go on and have an MI in the next 72 hours? It divides people into low, intermediate, and high risk of that. It is incredibly cumbersome. What I recommend you do is Google ACC-AHA 2007 guidelines. Go to page 85 of the Unstable Angina Guidelines, and the table is there. What we've done at our institution is we pulled out the table. It's on the wall of our ER. I can't list it for you now because literally it's 5 factors on one column, 3 risk stratifications on the top, and a bunch of junk in the middle. It's not easy to use. However, if you find somebody who is low risk of coronary artery disease on that table, and then you transfer yourself over to the table that puts them also at low risk of bad outcome in the next 72 hours, those patients can get discharged and get an outpatient workup. Their risk of something bad happening is 1.2% if you pull the data. I'm good with that. Okay, I'm good. You got to get to a point where you make a decision. I'm good with that. What we do at our joint is basically, if they are anything other than low, low, they're intermediate low, intermediate, anything other than low, low, they go through our chest pain unit and they get a workup through the ER. Okay, they go upstairs and they get their workup. Low, low gets an outpatient study done in the next 72 hours. They get an appointment, they come in, they get their study done. They get sent home on the appropriate meds, aspirin, et cetera, whatever they need, but they get sent home on the appropriate meds. We've had incredibly good success with this, remarkably. And this is at a county hospital with people who have no address, no transportation. I mean, we've had very good success with this. It does mean you do a lot of studies. It does mean a whole lot of people go through the system. The problem we've had is that the AHA guidelines, as a medical community, is the AHA and ACC guidelines have really lowered the bar very low as far as what's tolerable to miss. And they're not letting us off the hook at all. They made it hard on the history gathering. They made it hard on the troponins. By the way, the troponins they're recommending now are not Q6. They're recommending them Q8 to 12. Okay, we're getting into like, well, here, just change your address to the hospital address here because you're going to be here a while. They really have changed, they've changed the game significantly. I think what you have to do if you're dealing with these patients is know the pitfalls, make a decision ahead of time that you're going to standardize your practice on how you gather your history, what you do, you need an EKG and a troponin in all of them, how you make your decision to risk stratify them, and what you're going to do with them. And I highly recommend that you adopt a risk stratification scheme rather than go by sort of your clinical gestalt. It's just become too much of a quandary for us in this particularly the low risk group. The intermediate high risk groups, those are pretty easy. It's this, I think you might have acute coronary syndrome. I'm not 100% sure. Here's what I need to do for you to make sure you're okay. We're just not, and by the way, this is one of the highest, Neil can tell you the data, but one of the highest dollar amounts out there if you miss an MI as far as in pooled medical legal concern, this is the biggie. Okay, this is one of the biggest ones you're going to do as far as dollar amounts awarded. So, and plus it's just bad to miss an MI. So we've spun our wheels a lot on this diagnosis of acute coronary syndrome, and we've gone completely berserk with testing and schemes, et cetera. I think you have to come to some sort of peace with how you approach this, knowing where the problems are, and some sort of, I think, standardized approach that you take on how you are going to approach these patients in general. Any questions on this? I'm sorry, I wish I could tell you that it's magic. It's not.
And what's your position on repeat myoglobin?
I'll tell you, myoglobin. Myoglobin's a pretty good test. If you have it, I would use it. And in fact, it's integrated into some of these risk stratification schemes. I didn't mention it because most people don't have it routinely. But if you have it, it's a very good test. And it's used in the Erlanger protocol, and it's used in some of these other risk stratification schemes. And if you have it, I would use it. Yeah?
Most of these are based on 72-hour follow-up.
Mm-hmm.
Most of my patients don't have insurance, don't have primary care providers. A lot of them are undocumented. And we try to get them appointments with one of our primary care doctors. But, you know, they still have to pay $50.
Yeah.
A lot of them don't have the $50. And I'm sure you have a lot of those. You said you do something.
Yeah, our pay rate, we have a 4% pay rate, so. You know, if you have a follow-up issue, I would recommend trying to get them their risk stratification test done on the way out the door, if it's possible for you to do. One of the things that our hospital decided to do, because of we had one nasty lawsuit, that's all it takes to get the attention of administrators. Just that's life. And that's one of the things that led to our chest pain unit. And it's actually an adjunct on our emergency department, and it's staffed by cardiology, but we actually also sort of feed it and staff it, and it's all part of the ER visit. And I wish I could, it's a resource issue, and it is a problem, there's no question. And what we ended up doing, because of a horrific lawsuit, we ended up now with this chest pain unit, and that's how we ended up with ours. And I wish I had a good answer for you. It's a resource issue, and there's no good answer. 72 hours is the window we know. Now, if you really want to look at the data, there are 30-day studies. Some of these risk stratification tools didn't look at 72 hours. They looked at either 1 week or 30 days and then 6 months. So there is some wiggle room where you can at least make yourself feel better looking at data that you're probably okay on some of those folks. And I wish I could give you a better answer.